Welcome to the 4th edition of Neligan's Plastic Surgery. This video lecture accompanies the chapter text for Volume 5, Chapter 6, Mastopexy Options and Techniques. Breast ptosis presents in many forms and can be congenital in nature or acquired due to causes such as aging, weight changes, and pregnancy. Patients with ptosis generally desire the same result: youthful and perky breasts. However, due to wide variations in breast volume and tissue quality, ultimate results vary with each patient, and as a result, preoperative management of expectations is critical. This lecture aims to review the appropriate assessment of the ptotic breast and consider the many surgical options that can be customized to individual patient needs. These generally address repositioning of the glandular tissue and nipple areolar complex, as well as management of skin excess. We will discuss various scar patterns, parenchymal pedicles, and ancillary procedures. As with any procedure, complications may occur but can be minimized with careful patient selection, preoperative planning, and execution of surgery. It is important to keep the concept of ptosis separate from the issue of volume. In the cases of volume deficiency, augmentation mastopexy is generally the best option, while in situations of symptomatic macromastia, breast reduction surgery offers the definitive correction. The focus of this chapter is on a practical overview of managing the patient who presents with isolated breast ptosis, as opposed to breast volume issues as a primary driver of surgery. This will include understanding the pathophysiology of ptosis and assessing the multiple variations of ptosis, including tuberous breast deformity. When assessing ptotic breasts, multiple tissue categories need to be evaluated. The surgeon must assess the skin thickness and elasticity, the thickness and relative proportion of subcutaneous fat, the density and consistency of breast parenchyma, the state of Cooper's ligaments, the prominence of the pectoralis major muscle, and the nature of the bony base of the chest. All of these tissue layers interact to create the final appearance of the breast. The skin envelope can vary dramatically between patients, from thick and elastic in younger patients with developmental ptosis to thin and atrophic, more commonly seen in multiparous patients and those who have undergone massive weight fluctuations. Loss of skin thickness and elasticity can be a significant contributor to breast ptosis. The thicker and more elastic the skin, the more favorable the ultimate outcome will be in mastopexy. The amount of subcutaneous breast fat can vary dramatically between patients, and fat density can also vary. In general, a higher density of the soft tissues allows for a greater degree of control when reshaping the breast mound, as the tissues are less susceptible to gravitational distortion. A layer of fat padding under the skin can be very helpful in creating a smooth and natural result, camouflaging pre-existing irregularities in breast tissue. In women with soft, low-density fat, it can be very difficult to maintain upper pole fullness. Breast glandular tissue can vary widely in density and quality. Glandular tissue is firmer than fat and has more potential for reshaping and maintaining its shape over time. Mastopexy patients with a high proportion of dense glandular tissue can sometimes achieve a result that is comparable in appearance to augmentation mastopexy. On the other extreme of the spectrum, patients with fibrocystic changes can be more difficult to work with, resulting in irregular or lumpy appearing breasts if there is insufficient fat coverage to hide these irregularities. Cooper's ligaments originate from the pectoralis fascia and penetrate through the breast parenchyma to the dermal layer. These ligaments can be very helpful in supporting the breasts in a youthful position. With time, gravity, changes from childbearing, and weight fluctuations, these ligaments become attenuated, causing the entire breast to descend on the patient's chest wall. This discussion can further help patients understand why their breasts have changed over time and what the limitations of surgery are relative to these changes. Finally, the size and shape of the pectoralis major muscles and bony architecture of the rib cage and sternum are not part of the breast anatomy per se, but these structures do have an indirect impact on the breast appearance and position. Rib cage asymmetry can affect breast projection and symmetry. The presence of a pectus excavatum or pectus carinatum can also impact the appearance of the intermammary region and affects the likelihood of medial or lateral migration of breast tissue, particularly in the supine position. Once again, these bony and muscular anatomic features are difficult to adjust without more aggressive surgery, such as sternal remodeling. Pointing these features out to patients preoperatively can be very helpful in managing their ultimate expectations. The etiology of breast ptosis is multifactorial. Developmental ptosis can be due to naturally poor skin elasticity and weak Cooper's ligaments, often in conjunction with heavier, denser breast tissue. This may be exacerbated by naturally high inframammary folds, creating a pivot point around which the breast tissue can rotate. Other causes for ptosis can be situational, as in patients whose breast size has fluctuated due to pregnancies or weight changes, wherein the skin elasticity and ligamentous support becomes attenuated. Aging is also a significant issue, as the skin and soft tissue support naturally weakens over time. Finally, lifestyle choices can also affect the breasts. Patients who smoke or sustain sun damage, as well as women who rarely use bras or engage in frequent high-impact exercise, may accumulate more damage to the soft tissues of the breast. Raynaud created the classification of breast ptosis used by most plastic surgeons today. His system is predicated on the relationship of the nipple to the inframammary fold. In mild or grade 1 ptosis, the nipple is situated within 1 centimeter of the inframammary fold and is above the lower pole of the breast. In moderate or grade 2 ptosis, the nipple is 1 to 3 centimeters below the inframammary fold, but is still located above the lowest point of the breast. In severe or grade 3 ptosis, the nipple is more than 3 centimeters below the inframammary fold and is situated at the lowest portion of the breast. Brink further included the categories of glandular ptosis, pseudoptosis, and parenchymal misdistribution. Table 6.1 in the chapter text describes the specific anatomic variations for these forms of breast ptosis. Glandular ptosis is a specific variation of ptosis where the nipple remains situated above the lower pole of the breast, but the glandular tissue and nipple areolar complex begin to settle below the inframammary fold, creating a ptotic appearance. Pseudoptosis also involves glandular tissue descent below the inframammary fold. However, in this case, the nipple stays in a fixed position, leading to a progressively longer nipple to IMF distance. Breasts with pseudoptosis are commonly referred by surgeons as breasts that have bottomed out. The concept of parenchymal maldistribution in Brink's classification system refers to what is more commonly known as tuberous or constricted breast deformity, wherein abnormally tight tissues do not allow proper expansion of the breast during development, resulting in high inframammary folds, widely spaced cleavage, oversized and protruding areolae, and conical or tubular breast shapes. Tuberous breasts occur on a spectrum and can also be very asymmetrical in nature. The classification of tuberous breasts was further expanded by Grulot and von Heimberg. Patients seeking mastopexy often present with a concrete idea of how they wish to look after surgery. Unfortunately, many of these patients do not fully understand the anatomic limitations described previously. Additionally, patients need to understand that the forces such as gravity and anatomic features such as weak skin that lead to ptosis in the first place will still be present, and the future maintenance with more surgery is highly likely. When assessing a patient for potential mastopexy surgery, one of the most important initial steps is to separate and analyze the components of ptosis and volume. Breast volume needs to be assessed both as a distinct issue and as it relates to the correction of ptosis. As a general rule, performing a mastopexy without some type of augmentation creates the illusion of a smaller breast, even if minimal tissue is removed. This compression effect will be more significant in patients with softer, lower density breast tissue. Two examples are given here in which both patients actively wish to avoid the use of breast implants, and both patients wish to have perkier breasts. The patient on the left had thick elastic skin and a large volume of firm glandular tissue. In this case, due to favorable volume and anatomy, a significant improvement with good upper pole aesthetics was expected, and the recommendation for mastopexy alone was straightforward to make. A typical preoperative discussion regarding risks and expectations occurred. In contrast, the patient on the right had less favorable skin elasticity, lower density parenchyma, and less breast volume overall. There was potential for a fair degree of improvement with regard to ptosis. However, it was clear based on the preoperative anatomy that upper pole fullness would be suboptimal and the overall degree of change and improvement would be less dramatic. Thus, a much longer preoperative discussion occurred. With regard to the scar pattern, every patient wants the minimal amount of scars. However, it is important for them to understand that less scar is not a fair trade-off for residual ptosis or an unacceptable final breast shape. The patient should go into surgery knowing that the larger scar pattern is a possibility, so they are not surprised or disappointed afterwards if that scar pattern is used. This will allow the surgeon the greatest amount of flexibility in order to achieve the best overall result. Scars include circumareolar, circumvertical, and inverted T patterns. Pedicles can come from any direction, but the most common are inferior, superior medial, superior, lateral, and central mound. Parenchymal management can include autoaugmentation and internal suturing, internal mesh or pectoralis muscle sling. Ancillary procedures include liposuction of the peripheral breast or chest wall to improve contouring, as well as fat grafting to the upper pole to improve volume in this region. The majority of patients appropriate for mastopexy without augmentation will have grade 2 or 3 ptosis, which would benefit from circumvertical skin resection, which tightens the lower pole, raises the inframammary fold, and increases breast projection. An inframammary skin resection or inverted T-scar can be added in patients with significant lower pole skin excess and poor skin elasticity, where lower pole skin overlap would still be present after a circumvertical resection. In terms of pedicle orientation, the author has found the superior medial and superior pedicles to be the most useful. In the majority of patients, the superior medial pedicle represents a shorter distance to the nipple than an inferior pedicle. Additionally, this leaves the base of the pedicle in the area of the breast where fullness is most desired, and allows the pedicle to be suspended from above as opposed to being pushed up from the bottom, which is the case with inferior pedicles. With regard to ancillary procedures, autologous fat grafting is offered for upper pole fullness. Biologic materials such as resorbable mesh or ADM can also be offered in patients with particularly soft breast tissue and weak skin, acting as an internal support bra, and can be sutured to the pectoralis fascia. In patients with wide, poorly defined breasts, lateral chest wall liposuction is offered to sculpt the outer curve of the breast. Proper preoperative breast markings are critical in performing mastopexy surgery. Markings guide the surgeon with regard to symmetry and nipple placement, also alerting the surgeon to possible tilting of the torso in the seated position. The patient is marked in the standing position with shoulders relaxed. The sternal notch is marked with a V, and a midline is drawn down to the umbilicus. Following this, a measuring tape is draped around the patient's neck to assist marking the patient's breast meridians. Keep in mind, these lines bisect the breast, but they may not intersect the nipples if the nipples are medially or laterally situated. These marks are continued down the breast to include the lower poles, and then continued on to the abdomen. The inframammary folds are then marked by dashed lines. A large caliper is then used to transpose the inframammary fold onto the breast on each side. These marks are then remeasured from the low point of the sternal V marking to ensure symmetry. Next, each breast is rotated medially and laterally, and with each rotation a line is drawn as a plumb line from the transposed inframammary fold mark on the breast to the meridian line that had previously been drawn on the abdomen. These two new lines represent the extent of safe skin resection. Marks at 5 cm increments are drawn up the meridian lines from the transposed IMF marking to allow other points of reference in case intraoperative adjustments are necessary. A pre-made template with a keyhole of 42 mm or 38 to 40 mm in patients with smaller areolae is centered on the transposed IMF mark. The template is opened and matched to the medial and lateral rotation plumb lines. Marks are made 7 cm below the bottom of the keyhole. In cases where a circumvertical incision pattern is planned, dashed lines are extended medially and laterally and connected with the IMF markings. Another mark is made 2 finger widths or approximately 3 cm up from the IMF, which becomes the lowest point of skin resection. The parenchyma between the IMF and the marks 7 centimeters down from the keyhole is later undermined and either resected or, more commonly, sutured up to the pedicle to create more fullness. In cases where an inverted T-scar skin resection is initially planned, the skin between these markings is removed and the underlying parenchyma handled in the same way as previously noted. Finally, the pedicle is marked. The author's preferred technique for circumvertical mastopexy with the option of inverted T-scar conversion will be described here. After draping, one or both breasts can be quickly tailor-tacked at the proposed incisions, and the patient is examined in the seated position to ensure proper skin resection. This maneuver will confirm that the markings are not excessively aggressive. Next, the central breast is placed upon maximum stretch by the surgical assistant, and the areola is marked usually with the 42 mm cookie cutter and scored with a 15-blade scalpel. The previously made markings for the mastopexy are then scored with a scalpel. If a circumvertical skin resection is planned, the medial and lateral areas of skin undermining, marked with the letter U in the photos, are injected with approximately 10 cc per breast of local anesthetic containing epinephrine to minimize bleeding. Then the pedicle in large breasts, or the entire area within the markings in smaller breasts, is de-epithelialized sharply with a 10-blade scalpel. Electrocautery is then used for hemostasis and to contract the dermis. The lower dermis is released with cautery, shown here. A 10-blade scalpel on a flat handle is placed parallel to the skin and used in progressively advancing circular movements to undermine the skin in the inframedial and infralateral breast areas, leaving a few millimeters of subcutaneous fat to maintain blood supply and smoothness. After this, electrocautery is carefully used for hemostasis of this undermined skin. Next, a lateral flap of 1.5 to 2 centimeters thickness is developed down to the level of the chest wall, and the areas of parenchyma below the undermined inframedial and infralateral skin flap skin are dissected off the chest wall, leaving a thin layer of fat down on the fascia to maximize lymphatic drainage and create a gliding plane after healing. The parenchyma from the undermined area is usually maintained for maximum volume and sutured to the main pedicle using a 3/0 vicryl suture. In cases where a small reduction is preferred, this undermined tissue is resected and sent to pathology. Regardless, the tissue should be dissected out from the lower breast in order to reestablish a sharp, higher inframammary fold. At this point in the surgery, the pedicle is superiormedially or superiorly based, but unlike a breast reduction, this pedicle essentially represents all of the breast tissue besides the tissue connected to the lateral skin flap. If dense white glandular tissue is present, the author usually leaves a thin, less than 1 centimeter thick layer of this as part of the lateral flap to help maintain a smooth, firm contour of the lateral breast and to provide extra soft tissue support. The lower half of the pedicle is undermined at the level of the chest wall, and the pedicle, again representing the majority of the breast tissue, is rotated in a superior medial direction or shifted in a superior direction. This is then sutured at its deep lateral and inferior border to the chest wall using a 3/0 PDS suture. This stabilizes the tissue in a higher position during the healing process and elevates the new inframammary fold. Care must be taken not to over-elevate the tissue, as this can cause a distortion and over-rotation of the lower pole of the breast. The suture points are usually 1 to 1.5 centimeters above the original inframammary fold. Once the dissection and stabilization of the parenchyma in its new position is completed, the skin is temporarily tailor-tacked with a stapler and checked with the patient in the seated position. Based on the appearance of the breast, small adjustments in the pedicle position and the amount of skin resection can be made. Also, the lower breast skin excess can be evaluated, and if significant skin-on-skin contact is still present, the patient can be converted to an inverted T-scar pattern by simply resecting the undermined skin of the inframedial and infralateral breasts. This is also an excellent time to take a front view photo, which allows one to view one breast essentially completed while the other breast is in its original state. The patient is then returned to the supine position, and attention is turned to the left breast where the same procedure is performed, with considerations made for asymmetry correction. Once the left breast dissection is completed, it is tailor-tacked as well, and the patient is carefully checked in the supine and seated positions for good shape, size, and symmetry. If reasonably strong breast tissue or superficial fascia is present, parenchymal pillar sutures can be placed with real PDS in interrupted fashion for additional deep support. In appropriate patients with very weak tissues, additional support, such as a reabsorbable mesh, can be used as an internal bra to offload weight from the skin, sutured just below and lateral to where the parenchyma was sutured to the pectoralis fascia. Final skin closure is performed using running absorbable suture in layered fashion. Tuberous breasts are defined by constricted lower poles, a wide intermammary distance, conical breast shapes, oversized and protruding areolae, and an excess of herniated retroareolar breast tissue combined with the general paucity of breast tissue. All of these problems require reversal. High inframammary folds with constricted lower breast tissue need to be released and expanded. Oversized and protruding areolas with herniated breast tissue need to be corrected by reducing the areolar diameter. Finally, undersized and widely spaced breasts generally require correction with implant augmentation. Most of these cases are performed through a periareolar approach, which allows the minimum amount of scarring in the lower pole of the breast where expansion is needed the most. Prior to making a periareolar incision on the true areolar edge, a 40 to 42 mm cookie cutter is used to mark the areola on maximum stretch, and this is lightly scored for the later circumareolar mastopexy. A superior periareolar incision on the true upper edge of the areola is made for implant placement. Dissection is continued down the chest wall to create a dual-plane retropectoral pocket. This offers the benefits of upper pole submuscular coverage for a more natural slope and lower capsular contracture rate, while the majority of the lower half of the breast is subglandular, allowing for maximum tissue expansion. Fibrous tissue bands are then identified at the lower pole parenchyma, which are then radially scored to allow maximum expansion. A disproportionate amount of glandular tissue will be seen in the retroareolar area, and some of this may be resected to leave an even thickness of glandular tissue that is consistent with the remainder of the breast mound. After pocket creation, the inframammary fold is lowered as needed to create an optimal nipple to IMF distance based on implant width. Finally, circumareolar mastopexy functions to reduce the final areolar size as well as protrusion. It also acts to superiorly lift the areola by up to 2 to 2.5 centimeters. With aggressive lowering of the inframammary fold, which is generally needed with tuberous breast deformity, the old crease can create a double bubble appearance. The circumareolar mastopexy will tighten the breast skin around the implant, which redistributes the tissue and helps to reduce the appearance of the crease as seen in this photo. Finally, circumareolar mastopexies have a flattening effect on the breast, which helps to create a rounder, more aesthetic appearance in an otherwise conical-shaped tuberous breast. The author prefers a multi-layer circumareolar technique. The area for skin resection is marked with a vertical distance approximately 1 centimeter longer than the transverse distance to avoid a final oval shape. Then the area of skin resection is deepithelialized. Cautery is used for hemostasis and to shrink the dermis. A 4L suture is used in running whip stitch fashion to imbricate the dermis to take tension off the final closure. A deep subcuticular style placement of 4L is then placed to stabilize the diameter of the areola. Skin closure is completed with 4L monocryl. The patient is placed in a gently compressive surgical bra, extubated, and sent home after recovery from anesthesia. Pain is usually mild and easily controlled with oral medications. A gentle range of motion exercise protocol is also encouraged, but the patient is asked to avoid strenuous activity or lifting more than a few pounds. If drains are placed, they are usually removed once outputs are less than 25 cc's per day. Light, non-impact exercise can be resumed at 4 weeks, and easing into a full exercise routine can be started 6 weeks after surgery. The patient is kept in a soft, non-underwire bra after surgery and can use ice for comfort as needed. Underwire bras can be resumed at 4 to 6 months based on comfort. The risk of major complications with mastopexy is low. Acquisition of new scars on the breast is a primary trade-off for mastopexy surgery, and patients must be prepared for possible suboptimal scarring. Small wounds can be common along the incisions, often near the lower portion of the vertical scar or at the T-junctions. Wounds most commonly appear between weeks 3 and 6 unless there is an early issue due to poor blood supply. Reducing suture burden, reducing tension of skin closure, and strictly avoiding active smokers may all help reduce wound healing problems. Tissue necrosis, including loss of the nipple areolar complex, is extremely rare. Leaving thick lateral flaps and a broad-based pedicle helps to reduce the risk of this problem, in addition to proper patient selection. If ischemia is recognized intraoperatively, the pedicle should be checked for kinks to the blood supply, and conversion of an ischemic nipple to free nipple graft remains a reasonable maneuver within the first 12 hours. Some degree of postoperative asymmetry is to be expected, and more noticeable asymmetry can often be corrected using simple skin adjustments under local anesthesia. Some degree of ptosis will always recur, and some patients require retightening via their existing scars. Significant nipple malposition can generally be avoided with careful planning and proper preoperative marking. However, if nipple malposition is noted after surgery, the scar tissue should be given sufficient time to mature, and then adjustments can be made. Due to the challenge of lowering a nipple, it is often better to err on the side of under-elevating the nipple as opposed to over-elevating it when performing initial mastopexy. Finally, the most common disappointment will be due to a suboptimal degree of upper pole fullness. If this remains an issue, options include autologous fat grafting or implant placement. While these complications can occur, they are generally rare and relatively minor when proper preoperative planning and intraoperative execution is performed.